It's my pleasure to start the first session of this year's 20th edition of European Bifurcation Club meeting. My name is Jacek Legutko, I'm from Kraków, Poland, and I have a great pleasure to co-chair this session with Joby Thomas from Kadiam, India, and Tom Johnson from Bristol, United Kingdom. And we have great panel of experts, Mirvat Alasnag from Jeddah, Saudi Arabia, and Ziad Ali from Roslin, New York. They are online, and Ivan Ilic from Belgrade, Serbia, Steve Ramcharitar from Swindon, UK, and Satoru Mitomo from Chiba, Japan. The topic of this session is also, I believe, on time. Since the publication of the new European guidelines, we'll talk about intracoronary guidance of bifurcation stenting. So a real hot topic for many years, a lot of different approaches in Europe and also a lot of controversies on top of that. So I hope to solve at least some of them during this session. So the first speaker is Hideaki Akase from Yamaguchi, Japan, who will speak about risk assessment of side branch compromise after coronary bifurcation stenting. It would be the sub-study of the 3D OCT bifurcation registry.
Thank you, Chairperson. I'm honored to be here. I'm Hideaki Akase from Yamaguchi University in Japan. Today, I'd like to talk about risk assessment of side branch compromise after coronary bifurcation stenting. Side branch compromise is a serious complication in bifurcation PCI. Morphologic changes of the bifurcation segment by the stent are considered the main factor of side branch compromise after stent implantation. 3D OCT helps to clarify the special aspects of the bifurcation and the interaction between the stent and arterial wall. Thus, we considered that side branch compromise immediately after main vessel stenting might be more accurately predicted by 3D OCT. The aim of this study was to develop a risk stratification of side branch compromise and to investigate 3D morphologic changes of the side branch orifice. This study is a sub-study of the 3D OCT bifurcation registry involving 168 de novo bifurcation regions with a side branch reference diameter greater than 2 mm. Of these, the present study extracted cases according to the following criteria. As you can see, side branch compromise was defined as worsening of angiographic side branch ostial stenosis greater than 90% immediately after main vessel stenting. This figure illustrates 3D bifurcation appearance as assessed by 3D OCT. The white arrow indicates the direction of observation. In the parallel type bifurcation, the proximal course of side branch is clearly visible. On the other hand, in the perpendicular type, the wall of side branch is not visible. We conducted three-dimensional measurement of the bifurcation segment, focusing on three key geometric parameters. Side branch diameter is the maximum distance between the lumen borders of side branch ostium in a cross-sectional image during main vessel pullback. BPCT length is the distance from the branching point to the carina tip, measured in a longitudinal image. DPOC is the maximum distance from the course of main vessel and to the course of side branch in the first frame proximal to the carina tip. First, we focused on developing risk stratification of side branch compromise. Among the 168 bifurcation regions, 111 bifurcation regions were analyzed. We categorized the regions in two groups, those with side branch compromise and those without, and compared each parameters between the groups. In patient characteristics, there were no significant differences between the groups. The target bifurcation region with SBC were mostly located at the LAD, and those without were more frequently located at left main coronary artery. The prevalence of true bifurcation lesion was more significantly higher in SBC groups. The angle between distal main vessel and side branch was comparable in two groups. The prevalence of parallel type bifurcation was significantly higher in the SBC groups. In the present study, no differences were detected in the plaque distribution and components. Each of 3D geometric parameters was significantly shorter in the SBC group than non-SBC groups. As shown in these graphs, the cutoff values of 3D geometric parameters for predicting side branch compromise were determined using ROC curves. The cutoff values for side branch diameter was 1.77 mm, BPCT length was 1.8 mm, and DPOC was 3.96 mm. This slide shows how we develop OCT risk score to predict side branch compromise. We assigned 1 point to 3D geometric parameter less than or equal to the cutoff value and parallel type bifurcation. The score was calculated by summing these points. As you can see in the right graph, a higher risk score results in a higher frequency of side branch compromise. This figure presents a representative case. Before the procedure, the region had short geometric parameter and parallel type bifurcation, resulting in risk score of 4. Immediately after stenting, side branch compromise occurred as predicted the risk score. Next, we investigated 3D morphologic changes of the side branch orifice. 83 bifurcation regions were analyzed. This figure illustrates changes of 3D geometric parameters before and after stenting for two bifurcation type. Showing in the upper row for parallel type bifurcation and lower row for perpendicular type. For side branch diameter, there were no significant changes in either bifurcation type. However, BPCT length significantly shortened after stenting in both bifurcation type. In the parallel type bifurcation, even though DPOC did not change significantly, calculated DPOC minus distal main vessel diameter significantly shortened after stenting. This figure presents an OCT image of previously shown representative case. In a cross-sectional image, side branch diameter did not change significantly. This is thought to be due to the opposing effect of plaque shift narrowing side branch ostium and expansion between stent struts, widening it. In a longitudinal image, calculated DPOC minus distal main vessel diameter was shortened due to the carina shift. Additionally, BPCT length was shortened as a result of both of carina shift and plaque shift. Here is a summary of our findings. The incidence of side branch compromise immediately after stenting was related to shorter geometric parameters and parallel type bifurcation. The mechanism of side branch compromise may differ depending on the 3D OCT bifurcation type. The OCT risk score could predict side branch compromise with high probability. Thank you very much for your attention.
Thank you. We have like 4 minutes for discussion. Any comments from the panel?
I mean, beautiful data. Obviously, this is a score that is based upon OCT. I'm interested that you mentioned there was no association with different plaque phenotype, but obviously the limitation of OCT will be an ability to detect plaque burden. So do you think with IVUS the score would be the same or different? Would there be new parameters? This is geometric, but I wonder whether disease burden, where we've seen a larger plaque burden on the opposite wall being a predictor of compromise, that we're just missing it because we don't see it by OCT. Could you comment on the difference you might think between an OCT score and an IVUS score?
Thank you for your question. I believe our findings may adapt to IVUS, but there is a limitation, as you say. In the present study, there were no significant differences in plaque components and distribution, but there were differences by bifurcation type. In parallel type bifurcation, large plaque, eccentric plaque on opposite side of side branch, such as those extending from branching point to the coronary tip, is significantly associated with side branch compromise. But perpendicular type, eccentric plaque, repeat plaque around side branch was significantly associated with side branch compromise. But further study is needed in the future.
Thank you.
What diameter of the side branch did you take? The lumen diameter or the external elastic diameter? What's the diameter of the side branch you have taken? Is it the lumen diameter or the median diameter?
You mean side branch stent diameter?
Is it lumen diameter or the EM diameter?
It was a lumen measurement, wasn't it? Of the three metrics, the side branch diameter was lumen edge to lumen edge, right? Not EM to EM.
No, not EM, between the lumen borders.
So you might be missing the plaque there. So if you're taking the lumen diameter, you might be missing the plaque in the side branch. In which case, as Dr. Johnson has told, IVUS would have given a better idea about side branch diameter and plaque.
Well, I mean, the focus of plaque tends to be on the opposite wall to the bifurcation as a predictor for the compromise, rather than at the level of the carina or into the side branch.
Do we have time for one question?
Yeah, one more question.
We beautifully executed study, and this is the step forward towards the numbers in OCT and how to make decisions in PCI and bifurcations. What I would like to know, did you take into the account the extent of the disease in the side branch in analyzing this cohort of patients? I mean, if it's like longer than 10 millimeters in the side branch or shorter, did you notice that in the study?
Sorry, I can't.
I think about side branch disease. If it's like large, I mean, the plaque extends into the side branch. Did you look into that, or you didn't? Because I didn't see the numbers about it.
In the study?
In the study.
I didn't see analysis side branch.
Okay, thank you.
Can I just have one quick question, Tom?
We probably ought to move on, I think, Steve. Otherwise, we're at risk. Maybe in the coffee break. Thank you. That was a wonderful.
Thank you very much.
Sorry, Steve. We're doing well at keeping almost to time, and I know we started late, but it would be my pleasure to ask for Kazumasa Kurogi to come up to the podium to present real-time IVUS guidance for precise LAD ostial stenting as we shift from OCT to IVUS. We may be missing some presenters due to the fact there have been some issues with air travel into Germany. Or have we got an online presentation? Online. Fantastic. Thank you.
EBC
Kazumasa.
2024 meeting. The title of my presentation is Real-time IVUS versus Angiographic Guidance for Precise LAD Ostial Stenting. And this is my CEO disclosure. optimal stenting strategy for Medina 010 LAD ostial region remains unclear. However, in LAD ostial stenting, geographic myths in LAD ostial stenting have a significant clinical impact. First, if the stent placed too distally from the ostium, there would be increasing risk of restenosis because of suboptimal scaffoldings. On the other hand, if the stent is placed too proximally, protrusion of some strut into the bifurcation core may cause difficulties. So we will show you a case of Fortis male with effort angina. Angiography revealed ostial region in the LAD Medina 010. However, the limited range of motion in angiography systems failed to provide the LAD separation. And this is the IVUS image. You can see the slit-like region in the LAD ostium. And the percent plaque area in the LAD ostium was 52%, and we thought precise LAD ostial stenting is needed. Otherwise, LMT crossover stenting should be selected. So we inserted drug Ilic stent to LAD and IVUS to LCX simultaneously. While the first operator adjusted the stent position, the assistant operated IVUS from the side branch. So we confirmed the position of stent proximal edge while moving the IVUS catheter proximally and distally by the assistant. This technique using real-time IVUS guidance allows clear visualization of the stent proximal edge and ostium of LAD without contrast media. Final angiography showed promising result. And this is the post-stenting IVUS image, showed exact positioning of the stent proximal edge at the ostium of LAD. Regardless of the stent type, you can clearly see the border between the proximal edge of the stent and the balloon. So we investigate the feasibility and accuracy of real-time IVUS-guided LAD ostial stenting compared with conventional angiographic guidance. And this is the flow chart of the study. We enrolled 41 who underwent angiographic guide and 19 real-time IVUS-guided LAD ostial stenting, respectively. And this is the pre-procedural patient and region characteristics of the two groups. No significant differences were observed except guiding catheter size. And this is because the real-time IVUS guide needs over 7 French catheter. And this is the procedural characteristic of the two groups. So no significant differences were observed in most procedural characteristics. However, significant difference between the two groups were observed in the frequency of IVUS marking and number of coronary angiographies required for stent placement. This figure shows the absolute distance between the proximal stent and the carina. And compared with the angiography-guided group, the stent proximal edge in the real-time IVUS-guided group resulted in the significantly shorter absolute distance from the carina. However, it was not known how close to carina the stent should be placed. In other words, the definition of precise stenting zone. We analyzed the percent plaque area of LAD ostium and every 1 millimeter up to 3 millimeter from the ostium before the procedure. And this is the result. And cut-off value of percent plaque area of stent proximal landing zone to avoid the stent edge restenosis was reported to be 57%. And based on this result, precise stenting zone was defined within 1 millimeter from the LAD ostium. The overall incidence of precise stenting was 95% and 56% in the real-time IVUS and angiographic guidance group, respectively. Univariate and multivariate analysis showed that real-time IVUS guidance was the strongest predictor of precise LAD ostial stenting compared with the potential predictors in the three models. And this is the benefit of real-time IVUS guidance compared with angiographic guidance. First, real-time IVUS have no need for angiographic separation of LAD ostium. And second, IVUS is superior in spatial resolution compared with angiography guidance. And third, the IVUS in the side branch stabilizes the systems and reduces motion during stenting. And this technique might have some limitations. In case the side branch angle is wide, the IVUS plane would be diagonal, and stent would be placed distal more than expected. And next, we must consider the impact of stent elongation after stent deployment. And this is the conclusion. The optimal treatment of isolated LAD ostial regions is not known, but the treatment strategy should be determined considering anatomical factors and plaque distribution. And geographic misses in LAD ostial stenting might have a significant clinical impact, and accurate stent placement is desirable. The real-time IVUS guidance allowed for more precise stent placement at the LAD ostium than conventional angiographic guidance. Thank you for your attention.
Thank you, Dr. Kurogi. It was, again, great presentation and very important topic. Tomorrow there is a separate session on the treatment of the ostial LAD lesions, and usually the lesion in the ostium is associated also with some plaque in the distal left main. So the first question would be, what are the indications nowadays to try to position the stent just in the ostium of LAD instead of crossover stenting from left main to LAD? This is my first question.
Okay. Can you hear my voice?
Yeah, we hear you and see you very well.
Yeah, thank you. In Japan, it's 8 o'clock evening. Good evening. And thank you for question. The indication of ostial stenting, I think the precise ostial stenting indication is not clearly. But as you said, if the plaque burden is high in the LAD, left main crossover is recommended, I think. But plaque burden is relatively low. Actually, percent plaque area is under 50%. I think I can put the stent proximal edge safely, I think.
Thank you for such a lovely talk. It's nice to see Manel here. The question I have related to IVUS and the angulation. Basically, there is Medina who described the eyebrow sign in IVUS, whereupon if you have a very wide angle and obtuse angle, you have an eyebrow sign that predicts the possibility of closure of or compromise of the side branch. Did you use this in your evaluation at all in trying to predict, because you said that certain angles were unfavorable. Did you notice the eyebrow sign and a correlation?
Thank you. Thank you for a nice question. That's a very important point. So as you say, if the side branch angle is narrow, if you put the stent at LAD ostial stenting, I think the carina shift may occur and side branch would be compromised. So very narrow angle and plaque burden is high, I think it's not recommended for LED ostial stenting. This technique would be recommended in case the relatively wide angle, rectangular angle.
One final question. Have you looked at all at learning curve? I guess that's difficult in Japan where everyone has significant expertise, but we have to accept that this is not straightforward image interpretation. So has there been any assessment of learning curve in junior fellows to more senior or technician-based analysis in the cath lab?
Yeah, thank you for a very important question. I think I success for the first time, and I only one miss I experienced only one case of major dislodgement. So the key point is stabilization of the system. So we can stabilize the stent and guiding catheter motion by the IVUS deeply inserted into the LCX. And if there is a bilateral or Remus branch, I think the narrow angle of bilateral branch would be good for the observation of LED ostium.
Just a quick question, really. I do like the comparison using tip angiography versus the IVUS. But we've been in this club, and many years ago, there was a technique that was discussed, which was the Szabo technique, where you raise a strut in the proximal edge of the stent, put a wire in, and use that to stabilize. There was another technique also that people discussed, was to go up with the balloon, the stent a little bit so that it becomes a little bit fatter and avoid the movement of the stent. So these two techniques were used for stabilization. Do you think it would be sensible to have a comparison between one of these angiographic techniques and the IVUS?
But sorry, I can't follow your question. What versus Szabo technique?
Yes.
I'm not for sure because I never performed Szabo technique. I only experienced angiography guidance and real-time IVUS guidance. Sorry.
Yeah, one last question. So in most cases of this ostial stenting, after post-dilatation, the stent elongates. So is it worth taking all these efforts to precisely position the stent at the LED ostium?
Yeah, thank you. As you said, the stent, we would consider the impact of stent elongation after stent deployment, but I think it's a bench testing. So, but in the real world, in the vivo, I never experienced the elongation. Never experienced the major dislodgement by the elongation. I think the plaque friction would prevent elongation. I think dislodgement. I think.
Okay, thank you very much, Dr. Kurogi. It was excellent demonstration, would be discussed tomorrow for sure during the session dedicated to the treatment of ostial LED. And now we move on to the next speaker, Dr. Yoon-Bin Son from Seoul, Korea, and very important topic of prognostic impact of operator experience and IVUS guidance on long-term outcome after complex PCI, left main and bifurcations.
Okay. Thank you, Chairman. Good afternoon, everyone. I'm Young-Bin Song from Samsung Medical Center in Korea. Today, I'd like to talk about the prognostic impact of operator experience and IVUS guidance on long-term clinical outcomes after complex PCI, including left main and bifurcation lesions. Over the years, complex PCI procedures have been increasing. According to British Cardiovascular Intervention Society dataset, CHIP PCI accounted for 28.1% of total PCI in 2007 and increased to 36.2% by 2014. Unfortunately, these complex lesions was associated with worse clinical outcomes, including nearly double the risk of major adverse events compared to simple procedure. In this setting, operator experience becomes crucial. The previous studies have demonstrated that the high volume or operator experience was associated with a significantly lower risk of major adverse cardiac events, particularly in complex PCI, such as unprotected left main or those requiring rotational atherectomy. Additionally, intravascular imaging has gained a considerable attention for its role in optimizing complex PCI outcomes in complex lesions. The latest EBC guideline upgraded the recommendation for intravascular imaging to a class 1A in complex PCI. So, operator experience and IVUS guidance can improve clinical outcomes in complex PCI, but their interaction is still unclear. So, the objective of the present study is to explore the association between operator experience and long-term outcomes, and the interaction between operator experience and IVUS guidance on long-term outcomes in complex PCI. So we analyzed the data from more than 6,000 patients who have a complex coronary artery region undergoing PCI with drug-eluting stents from Samsung Medical Center. We stratified the data by operator experiences less than 5 years versus over 5 years and IVUS usage. The primary endpoint was cardiac death or target vessel myocardial infarction over 10-year follow-up period. The experienced operator used IVUS guidance more frequently compared to less experienced operator. The 29.6% versus the 24.8%. This trend was consistent across nearly all complex lesion types. And the patient treated by the experienced operator had a significantly lower risk of cardiac death or MI compared to those treated by less experienced operator. The adjusted hazard ratio 0.779, and this demonstrates that the operator experience positively influenced the long-term clinical outcomes in complex PCI. And the use of IVUS was associated with better clinical outcomes in both less experienced and experienced operators. Notably, in less experienced operators group, the IVUS-guided PCI resulted in 11.4% of a rate of cardiac death MI compared to 23.5% with angio-guided PCI. In experienced operator group, the 13.5% with the IVUS-guided PCI versus 18% without it. Interestingly, there was a significant interaction indicating that the IVUS guidance provided great benefit for less experienced operator. The beneficial impact of IVUS was most prominent within the first year post-PCI only in less experienced operator. However, as you can see here, the continued benefit was observed over a long-term follow-up period. Importantly, the patient treated less experienced operator using IVUS guidance had comparable outcomes to those treated by experienced operator using IVUS guidance. Next, let's take a look at subgroup analysis. As you can see here, the benefit of IVUS-guided PCI was consistent across different types of complex lesions, regardless of operator experience. Particularly, patients with left main disease benefit the most from IVUS guidance in both groups. In this slide, we particularly focus on bifurcation or left main lesions. As you can see here, the both less experienced operator and experienced operator benefit from the IVUS guidance. So when performing a PCI on these particularly challenging lesion subset. So, ladies and gentlemen, this is my conclusion. Both operator experience and IVUS guidance independently improved long-term outcomes in complex PCI. IVUS guidance provided greater benefit for less experienced operator, so IVUS should be strongly considered for complex PCI, especially by less experienced operators. The clinical implication of our study is that the systematic IVUS training programs were needed for less experienced operators performing complex PCI. IVUS guidance can help less experienced operators achieve outcomes comparable to those of experienced operators. Thank you for your attention.
Thank you. That's really provocative data. So I wonder, you touched upon the different lesion types. Yeah. Can it be assumed that the same cases are undertaken by less experienced and more experienced operators? So is more complex disease being undertaken by the more experienced operators?
Yeah, actually, as I've already mentioned earlier, the left main lesion is most benefit from the IVUS guidance in both less experienced and experienced operators. So I think if you treat the left main complex bifurcation, we should use the IVUS regardless of operator experience, I think.
Got a question in the audience.
Yeah, a wonderful talk,
Okay,
Deep Samedi. I wonder if you looked at, you used a dichotomous variable to define experienced and non-experienced. Did you all look at, how many years after training does that benefit of IVUS wear off? And on the other end, after 10 or 15 years, does it plateau? And then, so that's one question. And related to that is, I know your group has looked at definitions and sort of protocols for optimizing IVUS. Did you look at those that used IVUS, based on protocols rather than just generally utilization of IVUS?
Yeah, thank you for your excellent question. Actually, within the first 5 years of operator experience, actually the clinical outcome did not change in our analysis. So after 5 years, every single year, the clinical outcomes improved. So, but we have several limitations in our study. This is a single center study, and actually we have 7 interventional cardiologists, and most of them perform the PCI more than 200 procedures annually. So I think this result cannot be applied to other hospitals, I think.
Steve's question, and then from the audience.
Yeah, just a quick question. Thanks for a wonderful talk. I think the time scale of 5 years is what usually your cutoff. But I believe in BCIS, they give a number of procedures initially, which was around 15 left main, and they said that it should be mandatory to do IVUS in the left main. So, in your experience or in your study, was there any correlation with the numbers that you found that people had to do to be competent?
Yeah, actually, in our hospital, most cardiology interventionists to perform PCI, actually the average 200, over 200 PCI, so, and including left main lesion.
So specifically for the left main, how many left mains?
Okay, I'm not sure, but
because
yeah.
This was 15.
Yeah.
16.
Yeah.
16.
Which is the same as the Chinese data, so in China as well, they found that about 15 or 16.
Thank you very much for your talk. The experience was defined with the number of procedures performed in year, or also with the experience with intravascular imaging, because I think the less pronounced impact of intravascular imaging in patients with high experience is even though that they can better interpret the angiography based on their experience with intravascular imaging. What I learned from intravascular imaging is that I can better interpret the angio, because I have seen a lot of cases with angio and intravascular imaging. After that, I can predict maybe this is dissection, this is plaque rupture, this is etc. So, did you measure the number of experience with intravascular imaging in this study?
Sorry, I don't understand.
I mean, the less pronounced impact of intravascular imaging in patients with experience, with high experience, could be due to the fact that they can better interpret the angio based on their experience with previous intravascular imaging that they did.
The counter to that was, as you observed, that in fact the more senior operators tended to use imaging more.
Yeah.
So although they may be better in doing it angiographically guided, they're actually using the imaging more. I mean, there's one further question before we move on. Obviously, the Samsung Centre is a large centre with huge expertise, and obviously Renovate, which also has provided some very important information, shows very similar results, but a very large proportion of Renovate was randomized, was recruited in Samsung. So I'm interested by the fact that we don't see a benefit, a clear benefit of imaging in bifurcation, but we see a benefit in left main. And that's been also observed in other studies. Could you comment on maybe why we see left main as a lesion type that seems to benefit over other bifurcations?
Yeah. I totally agree with your opinion. Actually, we have a lot of type of bifurcation. So I believe in true bifurcation, IVUS guidance may be helpful, but if non-true bifurcation, actually it is hard to see the benefit of IVUS guidance.
Okay. Thank you. Okay. I think we've run out of time, but this moves on beautifully to now Niels Holm to come and provide us with some insights from the October study. And I think there is probably a need for us to discuss this issue around true bifurcation, non-true, and complexity of stenting, as Niels may allude to in some of the findings from October.
At least try. Thank you very much. Thanks for the kind invitation. Pleasure to be here. My disclosures. So the October trial was a randomized comparison of imaging-guided PCI versus angiographic-guided PCI in true bifurcation lesions. We had a primary outcome showing a 30% risk reduction with OCT-guided PCI or angiographic-guided PCI after 2 years. We also had the pleasure to collaborate with Greg Stone and Ziad Ali on this meta-analysis was published in the spring, showing that there's an effect for 22 randomized trials on all-cause mortality, cardiac death, target vessel MI, ischemic remetaculation, revascularization, and so on. And that, of course, supported the 1A indication for intracoronary imaging guidance by IVUS or OCT for performing PCI anatomically complex lesions, in particular left main stem, true bifurcations, and long lesions. Now, this is only 5 weeks ago, so I don't expect major changes already, but looking to my inbox the past 5 weeks, certainly something is going on. So a massive movement in the right direction, but let's revisit in a year the effects of this 1A indication. So we, in the October trial, we have done a number of sub-analyses, not fully done yet. So this is a summary of some of the presentations that we have done so far, and these are sub-analyses, so should be viewed in that light as secondary analysis. If we look at the stent techniques that were performed, one stent techniques appeared to benefit particularly with OCT guided with a roughly 50% reduction in MACE, significant. It was roughly 1/3 of the cases. So even if we do bifurcations just with POT and kissing, well, there's a substantial benefit of imaging guiding. With two stent techniques, we couldn't really see the same substantial effect. There was probably some effect, adding giving numbers to the primary outcome. But two stent techniques, we pushed for that at the time where we also got COVID. And to do complex two stent techniques at the time where you're told by management and experts to do very short procedure and get the patients out of the cath lab was probably not a very good idea, and we could clearly see that in the quality of OCT guiding at the time. A finding that we were a bit keen about was in the October trial, we mandated to do the first pullback after plaque preparation. So when the physician was satisfied with plaque preparation based on the angiogram, they did the first OCT pullback. And then in 1/3 of cases, by core lab assessment, there was indication for doing something additional. This was only identified in roughly 43% of cases with the indication, but some additional work was done in these cases. We couldn't see that the leftovers that were not treated additionally, that they really affected outcome negatively. We also found that if we used reference size measurement for limiting the largest balloon and stent size, that was very safe. So if you have a 3.5 vessel based on media to media measurements, then you can go up to that value with quite high pressures and still have the same level of perforations as with angio-guided PCI, and then still use larger balloons overall. We also found that accidental abluminal rewiring occurred in roughly 5% of cases. It was identified in roughly 50% of cases by physicians, and then the wire was repositioned. Some of these cases where it was not identified led to unintended stent deformation, but there was also a lot of other mechanisms for that. I will touch a bit more upon that tomorrow. But the left main is a particular issue for unintended stent deformation. Roughly 18% of cases had some level of deformation. And that clearly relates to outcome. Until now, all of the things that we have looked into, unintended stent deformation is the strongest predictor of increased MACE after these procedures. If you correct unintended stent deformation, the risk is 0. So, edge segments. We saw in the Nordic bifurcation studies that roughly 40% of the events were related to edges. So we had a lot of focus in the training that the physician should avoid leaving edges with residual stenosis more than 30%, major lipid plaques, and major dissections. And that turned out to be quite effective. We had a sub-study presented here at ESC where we saw that it was still some fraction of cases, roughly 25% of cases, where there was more than 30% damage stenosis in the edges. But were these protocol errors? No, it's called. Sorry. So what we showed was that, or what we currently look into, is that in these cases where we exceed the 30%, not all of them are protocol violations, because a lot of these cases have quite extensive disease, diffuse disease, so it's simply impossible to make full coverage. If we look at edge disease for the amount of lipid, we could also see that despite the instructions, there was still some protocol violations, but probably quite limited compared to a angiographic guided population, but we did not have blinded OCT in that population. So based on that, we only had 2 events out of the 600 cases where we could verify there was a edge-related event. So extremely low numbers with this strategy. There was one additional case with edge-related event, but there was no OCT guiding in that case. So I got a lot of questions during many talks, and the most frequent question since the presentation of October is, if we can only do one OCT pullback, which one should it be? And I have a bit of problem with that question because all the 22 trials that went into the meta-analysis all mandate 2 pullbacks, pre and post. So now we want to specify a single pullback instead of going with the evidence and have 2 pullbacks at least. So if we look at the October trial, we couldn't really see an effect of missing out of the pre-pullback. But if you do not do a final OCT pullback, it's clearly related to worse outcome. So there are multiple mechanisms for that, of course, but it's just to emphasize you can have a carefully tailored plan in a very simple lesion, and you probably can do fine with a pre-pullback. But in complex cases, you can mess up so many times during the procedure that you need the final pullback to verify that you did a good job. So in terms of events, the important number is down in the lower right corner, that we only had 3 angiographic verified events where the OCT looked normal in that particular segment. Meaning if you verify that by OCT you fulfill the criteria of the protocol, the risk of having an event is extremely small. So again, you can see the top numbers here, 7 and 2 angiographic verified. There was no OCT performed in those cases, in those segments where an event subsequently occurred. So the biggest predictor is not doing OCT. And again, I'll just go through this very fast. You can see the side branch is still the problem. And in particular, if you don't image the side branch, you don't discover that you have underexpansion and so on. Left main, we also saw an effect, not significant, it was a small subgroup, but we saw an effect despite 37% was guided by angio in the angiographic arm. By IVUS in the angiographic arm. So just selecting patients is probably not enough. You need to do it routinely in all your patients. And again, left main, it's the circ that causes the problems. That's where we find the events that enters into the cath lab. So in conclusion, OCT-guided bifurcation PCI is associated with improved clinical outcomes. 1 stent with kissing, clear effect of OCT guiding. 2 stent techniques, more variation in procedural quality. And we saw a likely effect of COVID-19. OCT-guided stent sizing is safe and efficient. An OCT-based edge strategy appears efficient. Unintended stent deformation contributed to MACE. If you correct unintended stent deformation, you will have no additional risk. Segments not evaluated by OCT are left in the dark and associated with increased risk. Thank you very much.
Thank you, Niels, for conducting this very important study and all those sub-analyses which are, I believe, also very important. The question about stent deformation, because this is going to be the hot topic and it is also related to the ongoing discussion on the experience of operators and outcomes of the procedures, how to diagnose stent deformations, which they are sometimes even overlooked with OCT, as you've shown in your study that some of those was not treated.
Yeah, I think it comes down to training. This is by, to dive into it, use it routinely, and then get feedback on your cases. So one thing is to do it in clinical practice, but if you are not trained or getting feedback, you will not develop further from that. Some of these findings are quite subtle and can be difficult to identify even with OCT, and by IVUS they're completely missed. So I think it's about the training, and it's about working with the quality of your work and interpretation.
Congratulations for this interesting paper that is one of the most important in the last years. But my question is about the diagnosis of stent deformation. If you can see stent deformation, why not correct it? So why patients were left without a correction after the diagnosis? This is an unacceptable result.
Yeah, so I believe that if it was identified by physicians, it was mandated to correct it, and it was done actually in the vast majority of those cases. But we have a core lab evaluation afterwards where we saw that about half of those, the true numbers, were not identified by the physicians and were not corrected. So, and it's also by protocol, we didn't contact the centers and ask them to bring in the patient again for corrected, and then we would start to affect the outcomes. So we saw something in the core lab that where, okay, get sweaty hands, the patient is left out there with a severely distorted stent that was not identified by the physician. But that's about training.
This is not the first study showing that, because you remember this sub-analysis from Excel trial showed absolutely the same with IVUS guidance. There were some like 8 or 9% of stent deformation which were overlooked by the operator using IVUS, and this was also independent predictor of MACE at follow-up.
So I think the 1 versus 2 stent data is interesting, although we may be reading into it too much. I mean, I know that the confidence intervals overlap with Unity, but you haven't presented either here nor in the New England Journal whether there was an interaction for the primary outcome by 1 versus 2 stent approach, and if there wasn't, then we're just reading into it nothing really.
Yeah, so there was no interaction.
Okay.
Yeah.
So I think the important thing is for people in here is not to think that there's no role for imaging for 2 stent approaches because there's no interaction. And the second thing, which is the point, is I think we'll have more information around the upfront versus the upfront and final OCT from the Octavius trial, because in the first 100 patients from that trial, they randomized the patients to either just a final OCT versus an upfront and final OCT as well. So we're still waiting that data.
There is one more question.
Congratulations again for the study. There is one question which is for me intriguing. It is the fact that the curves start to diverge from the moment 0.
Yeah.
And I cannot find in the paper a true reason for that. Probably you have a better insight and you can explain what's the main driver for this early divergence of the curves. They keep on diverging, so it probably does not affect the final conclusion, but it is anyway intriguing.
Yeah, so on the day of the procedure, we had all kinds of events, but it's of course mainly driven by periprocedural myocardial infarction. But these were by the modified SCAI definition, meaning these are quite considerable myocardial infarctions. So the procedure is probably more predictable if you do it imaging guiding, since you have lower numbers. But we also had catastrophic cases. This population had a lot of very sick patients. So we had patients dying on the table. We had multiple cases brought up back in the cath lab during the day after procedure. And so it's a mix of events, but of course, periprocedural myocardial infarction is the major driver for the big jump in the beginning. But certainly a number of cases went back to the cath lab within the first 48 hours.
Okay, thank you, Niels. Great presentation. And we move on to the last speaker of the session, Dr. Zlatko Mehmedbegovic from Belgrade, Serbia, and he will talk about long-term imaging follow-up after angio-guided left main primary PCI.
So how do I switch with this? Good morning, everyone. It's a pleasure to be here today with you. So my topic is long-term imaging follow-up after angio-guided left main primary PCI. I came from Belgrade, Serbia, from University Hospital Clinical Center. And just to put some light into our work, it's common sense that left main PCI has high inter-hospital mortality and unfavorable long-term outcomes. And despite the recognized benefit, rates of imaging in this situation are really low. And we also know that angiographically undetectable stent malposition occurs more frequently in large bifurcation anatomies such as the left main. And on top of this, long-term intravascular imaging evaluations of angio-guided unprotected left main PCI are lacking. We don't have reports about this. And we started with our population in our center. In 15 years, we had 209 patients undergoing primary PCI left main. Out of them, 30 die in hospital. So 21% die during the follow-up. So we ended up with 50% of the patients being alive and being our cohort to screen. And when we looked at the Kaplan-Meier survival curve, this is the cardiac mortality, and this is 100% true because we have the national registry based on the social number. We can see, as expected, that these patients die usually immediately after the procedure. And if we look according to the post-PCI ejection fraction, you can see that most patients died due to the low ejection fraction and heart failure. But when we looked at the data after 90 days from the procedure, we can see that there is no more effect of the low ejection fraction, and the patients with preserved ejection fraction still have events. So we get to the objective of our study to perform the long-term OCT imaging of DES implantations in patients with angio-guided unprotected left main PCI who had uneventful clinical follow-up. So we ended up screening 102 patients and finally performing OCT in 30 patients who consented to undergo angiography and OCT. They did not have any symptoms. They did not wait for the coronary angiography. They were screened and followed up by the investigators. This was our protocol, which we conducted every patients. After performing OCT, we evaluated the run online for the quality to make sure that the image was good enough for quality. And then we evaluated whether there was some indication for PCI. Indications for PCI were great, significant malposition, more than 400 microns and more than 1 millimeter in length. Lumen stenosis less than 4.5 or FFR less than 0.8 or some unrecognized stent deformation at the baseline procedure. If everything was fine, we completed the procedure. If not, we performed the PCI and then repeated the final OCT. How we conducted the analysis, we divided the treated segment on 3 subsegments. This is the left main, polygon of confluence, and distal main branch. We analyzed every cross-section, so it's 0.2 millimeter slices. And the primary point of our analysis was the percentage of covered, uncovered, and malapposed struts by segment. The main secondary endpoint was the impact of malapposition distance on vascular response and struts coverage. And we have a few additional secondary endpoints, which I will skip for due to time. So just to get a glimpse of the baseline population, so the 30 patients, mainly presented as STEMI. They were uncomplicated clinically. Only 6% had cardiogenic shock. True bifurcation in 20%. TIMI-01 flow was spotted in 10% of the patients. Single stent strategy was in 90% of the patients, with only 3 patients receiving 2 stents. Optimization techniques in 18%. We performed POT and kissing in 37%. And we ended up with optimal final results in all patients, achieving final TIMI-free flow. Post-PCI ejection fraction was 49%. And a few words about the OCT feasibility in this situation. You know it's not always easy to perform the OCT in left main. We achieved optimal image quality in 97% of the patients with analyzable stent measured length of 1.7 millimeter. So we all up performed more than 5 years from the baseline PCI, 1,623 days. And we found that we had abluminal viral crossing by wire or OCT in 20% of the patients, which had to be corrected during the procedure. We also found that the overhanging struts were present in 83% of the patients across the side branch, with no intimal proliferation reaching 58% of the side branch diameter on average. And we spotted unintended stent deformation in 10% of our cases. We also seen evidence of thrombus in 4 patients, mainly organized, but more importantly, we seen neoatherosclerosis in 1/3 of the patients. So we finally ended up performing ad hoc PCI in 57% of the patients, with 16 patients receiving target lesion revascularization in total. So quite a lot rare PCI in this population. So we now come to the stent analysis. We analyzed total length of the stent for 21.8 millimeters, and we found that the minimal position area was quite larger in proximal segments, the left main in POTS compared to the distal main branch segment, despite having good numbers for the mean stent area of 14 and 12 millimeters in proximal regions. But we saw the minimal stent expansion was suboptimal in these regions, reaching 72 and 60% in the POTS region. So we come to the primary endpoint, strut analysis. We ended up analyzing more than 30,000 struts for this analysis. So we found that the total covered struts were suboptimal in left main and POTS region, reaching 83 and 85%, while in distal main branch we had good strat coverage of 94%. We also found quite a lot malapose strats in these proximal regions, reaching 12 and 14%, and significantly malapose strats reaching 8 and 10% in these regions. So we then looked at the difference between the proximal reference area and the mean stent area. This is the black circle on this image, and we found to be positive in the proximal regions, being 3.5, 4.8 square millimeters, and negative in the distal branch. And this was significantly correlated with the percentage of covered strats and also with the percentage of malapose strats. So then we looked at the distance of malposition distance as strat coverage. This is the just indication of this 6 consecutive slices with 2 strats going away from the intima. You can see clearly how they were initially covered and that they become uncovered. And when we looked at the impact of malposition distance with cutoff of 400 microns, we have significantly malapose strats to be also less likely to be uncovered. So the key findings of our analysis are at the long-term follow-up. The strat coverage is not optimal in proximal bifurcation segments. Although pot and kissing balloon inflations were frequently performed, late malposition and stent under expansion were common. Strat malposition distance affects strat endostalization, and we also found high incidence of subclinical de novo atherosclerosis and restenotic intimal hyperplasia. Thank you.
Zlatko, thank you. Again, fairly provocative data. These were 30 cases that were brought back having had completely uncomplicated clinical outcome. So
Yeah.
you wonder what the cases that had harm looked like. How does it change? Does it change practice in Belgrade? So the cases that the Gantt chart of the patients treated for left main disease, fairly little amount of index imaging. Is that correct?
Yes, only one patient had IVUS during the baseline, but it was a SCAT case, so we had to use IVUS to ensure the position of the wires. How does it change? It certainly changed my mind, seeing all these cases, and I hope that now we can perform imaging baseline more, but also there's a question whether we should now consider performing imaging in other patients, which are fine, and after all these years, it's a provocative question, but it has to be considered now in this light.
Yeah, in this core, the use, as you said, when this imaging is very low, and it's a reality. It's not your center, it's every center. If the use of intravascular imaging, like main PCI, is not as high as it should be,
yeah.
It's even lower in these settings. We analyzed this in Spain, and it's really in these dramatic cases, the operator wants to do the job immediately, restore the flow, put the stent, and send the patient to the CCU because you don't want any more problems. That, my recommendation, because I used to employ just a final check with IVUS in these cases, is now we have integration of the system. To do IVUS is just seconds. You don't use maybe automatic very slow, just do manual very, very fast. And you can identify gross cell expansion, gross malposition. You just fix immediately with very short inflations. And these patients are most vulnerable to these problems. And we analyze what is the cause of death of these patients, and many of them, have sudden death in the first month, which is many times maybe thrombosis of the stent in the left main. And sometimes maybe it's a poor LV, but these cases many times go to ICD. But some of them were suspicion of probable stent thrombosis. And these are very vulnerable because the flow in this vessel is low, they have poor ejection fraction, they are hypotensive. Yeah. The drugs, sometimes you are relying on the oral pills or ticagrelor or prasugrel. They are not acting at the time of implantation because they take longer in these patients. Then you need also more intravenous drugs. But my recommendation is please use a final check of imaging to see if any gross abnormality in the stenting. With the final IVUS or CT, maybe IVUS is better because you are not using more contrast. But it has been increased, definitely.
Thank you for that comment.
Steve?
Just one quick question. in the patients that, you know, in a primary setting, there's so much physiology that goes on.
Yeah.
And vessels generally are more restricted and constricted in that setting. Have you seen cases where people came back and had an angiogram, let's say a week or so, you had bystander disease, as the case may be, and imaging was performed and showed malapposition at that point? Or, you know, in other words, when the adrenaline surge was, and is that something that you would consider? Like, if we're doing left main in a situation where there's a primary PCI, there's a cool-off period, you bring the patient back and then re-image and optimize the stent?
You probably tried to explain why the reference area was larger than the stent due to the spasm during the primary procedure, yeah. But people don't like to re-image the left system if you do it the right when there's stent protruding. You don't want to be the one who's distorting that stent. You want to leave it to rest. Probably that's not the situation where you would routinely image these patients afterwards. At least in my practice, I would not go near, because you saw that we had in 20% of the patients subintimal passage of the wire, and that was really frequent when the stent is placed ostially.
One final question.
So, even if you do a final IVUS pull back at the end of the procedure in a STEMI setting, and if you find few malapose stents, would you go for a post-dilation then, or would you wait for some time because you got a good flow there, and you might end up having a slow flow with post-dilation? So would you recommend to go for a dilation right there, or maybe a couple of weeks later?
Well, it's a tough question for me to answer, but I think immediately if you see malapposition, significant malapposition, you should try to correct it.
But we know that the malposition won't cause much events, as we know now with studies. Compared to antral expansion, the malposition wouldn't cause much stent thrombus or stenosis. So should we address all malposition right away, or because at the cost of slow flow and possible death on the table?
Yes, I understand, but I would not leave the large malposition left main under any circumstances, I think.
Zlatko, thank you. So I think we should wrap this up. It's a lovely presentation. Thank you to the panel. Thank you to the audience. I've thoroughly enjoyed this session, which I think has identified really the importance of imaging. We're in a new world with Class 1A recommendation in the setting of chronic coronary syndrome. But I think actually across the talks that we've had indicated really the role for imaging both pre and post PCI, and then the consequences if we don't undertake imaging in terms of what we see late. And I guess the message that's fundamental is we still have lots to learn throughout the whole of the procedures we undertake. But thank you for very stimulating talks.